Welcome, everybody, to another session of Impacting Patient Care with Chiropractic Radiology, a case study approach with Dr. Jeff Rich. Glad to have everybody with us today. And in the past couple sessions, Jeff's gotten very creative with his tablet and with the images that he's showing us. So look forward to another interactive and interesting session. Just a reminder, we are recording this session, so it will be available at a later date if you need to watch it. I will be emailing the test link to those of you that registered so that you can take the test and qualify for your continuing ed hour. And I believe, Jeff, during the presentation, if people have questions or comments, they can speak up at that time, and then we'll also give them some time at the end to ask questions, correct?
Yep, that sounds really good.
All right. Well, with that, take it away, Dr. Jeff Rich.
All right. Well, it's good to be with everybody today and show you some new cases that have come through since the last time we were together, and hopefully it'll be some real practical radiological issues that you see throughout your week in practice. The little quiz that we have for you to take afterwards, it's 6 questions. And don't want that to be hard, so I'll be very clear on some of the things that you'll want to know on that. So just if you have any questions as we go, just interrupt and keep going. We'll keep going. All right. So to remind yourself, this is the flow. The 4 Ds are really how I'm teaching radiology now at Northwestern. It just represents how you approach your cases every day. You start out with detection, and of course the biggest issue of all here is to define the abnormality. So I like to have a few cases here where you're just looking, and this is hands-on. This is you doing it. This is you practicing radiology, getting better at it, being reminded on the basics. But after you detect it, it's real tempting just to slam dunk it and try to figure out exactly what it is and jump to your diagnosis. But if you slow down a little bit and just stop and say, I saw something, what am I seeing? What are the forensics? Exactly what am I seeing? Just description. Don't worry about not knowing what it is. Getting a careful description is, I think, very important for the practicing clinician, because you've got to determine if something is aggressive or non-aggressive. I mean, that's your job, to do that quickly. If it's non-aggressive, leave it alone. If it's aggressive, you need to ship it out. And really making that decision is even important as to whether or not you would send it to a radiologist anyway. So you're going to be doing that. So you need to slow down, and we're going to really focus on some of those issues of aggressive versus non-aggressive today as well. We'll try to think of differential diagnostic considerations for these cases. We'll try to get our top 3 things there. And most importantly, and the whole point of doing imaging is to change things, is to impact patient care. Just to remind you, a case of, for example, diffuse idiopathic skeletal hyperostosis. Big, long diagnosis. Who cares? Why not just call it degenerative joint disease? It's pretty much the same thing, right? No, it's different. It's different. You need to distinguish this on X-ray, not because you like ruining people's insurance coverage by giving them a diagnosis. You like to diagnose it because of the associations and complications of diffuse idiopathic skeletal hyperostosis that impacts your patient care, whether you are a Gonstead practitioner or some sort of a mixer that every philosophy in between. Everybody wants to know the kinds of associations and complications that are going to change their patient care. And that's kind of the whole point of the flow of radiology. That's why we do it in the first place, is to change things. So keep that in mind, these 4 Ds as we go. All right. So with that in mind, of course, we want to start with where's Waldo? Just practice again with detection. So I admit the next couple cases are hard. They're hard to find the finding, but what I want you to do is chime in, is just go ahead, and if anybody, you don't need to even name your name, just tell me where the finding is. Of course, here's the left. So that'll if you shout out the answer as far as the finding, don't give me the diagnosis now. I'm just saying, where is the location? We'll worry about the diagnosis in a minute. All right, anybody see see something that catches?
Right femoral neck and looks like in the pelvic basin area.
Okay, good. So I agree that that area right there is probably what catches our eye for detection. That might catch your eye. Anybody know what that little thing is?
Is it a phlebolymph?
Yeah, so that's just a little calcified emissary vein, a little phlebolymph, no big deal. How about that? What's this, everybody?
Is that an IUD or what?
Yeah, that's a copper T intrauterine device. It's a little horizontal, probably retroverted uterus, and that's what makes it look a little strange. Typically, you can see the T better for these. But, so that's an IUD. So that leaves us with this finding here. All right, so good. So let's see if we can make that a little bigger here. All right, so now we make the finding. It's a bone lesion. Do you guys favor this being an aggressive bone lesion or a non-aggressive bone lesion? And why or why not?
Non-aggressive.
Anybody else want to vote?
Non-aggressive.
Non-aggressive.
Okay, so everybody's saying non-aggressive, and why do you say that? What's the main reason that you're saying that?
Well marginated.
Right, good. What else? That's a big one.
No periosteal reaction.
Good. I like the periosteal reaction comment, and the reason the periosteal reaction comment is so good is because periosteal reaction is evidence of cortical breakthrough. If you're playing cards, ace is high for a lot of the card games you play, for trumping and all that. And the ace, the finding that is definitive for an aggressive tumor is cortical breakthrough. If you only had one finding, it would be cortical breakthrough. The thing is, when you see periosteal reaction, like Codman's triangle or the like onion skin or whatever, we used to learn all those terms. That's evidence. The reason that is so important is that it's evidence of cortical breakthrough. Of course, if you have a large soft tissue mass out laterally or something on this case, then that would be evidence of a soft tissue mass would be evidence of cortical breakthrough as well. Good. So we're going non-aggressive here. It's solitary. It's non-aggressive. Any other descriptors? How would you describe this? Now, what are some descriptors you would say?
Radiopaque.
Yeah, radiopaque. Good. What else?
Confined.
Yeah. So a confined, oval, radiopaque, kind of homogeneous. It's really evenly opaque. Homogeneous radiopacity. Look at the edges of it. Are they really, really smooth, or do they have some irregularity to them? Just a little, what do you think?
Smooth.
Very smooth.
Couple of votes for smooth. Anybody else?
Well, I would just minimal irregularity. I mean, it's not just classic a line, but it's certainly not expansile by any means.
Yeah. So what I mean by smooth is, so there's a smooth circle right there. I mean, those edges are perfect. And on these edges, there is a little bit of, it's oval, but it's called a brush border. Anybody heard of remember the brush border? So this is a homogeneous oval radiopacity. It's solitary. I agree that it's non-aggressive. Now we're trying to figure out the diagnosis. Sometimes they have what's called a brush border, and they're solitary, like this. Anybody want to throw down the diagnosis for me now?
Well, a bone island or a non-ossifying fibroma or a fibrocortical defect would be your three, I would think.
Right. And of course, this is not around the cortex. They're a little older. So that's a young person. NOFs are usually going to be bigger than this, but that's a good thought. These are all this. So yeah, this is a bone island, and I guess why I'm reviewing this is these bone islands are what's called leave me alone lesions. You need to be able to be confident and say, this is non-aggressive. This is not a big deal. I'm going to leave it alone. I'm going to leave it alone. And why is it so important to leave it alone? What do I mean by that?
Don't send them to a specialist. Don't get advanced imaging. Don't biopsy. Just don't send them down a rabbit trail. Yeah,
it's a rabbit trail. I'll tell you what, you start following up a bone island and you decide to get a bone scan to start out with. Just let's start with a bone scan, see if it's active. The problem is some of these bone islands can be a little bit active. And so you do a bone scan and they can be a little bit of uptake. And all of a sudden you're in trouble because now you got what you thought was a bone island that's showing uptake, and now all of a sudden they're getting an MRI, then the pathologist sticks a needle in it and he's having a bad day or he's a bad pathologist and he calls this an osteosarc. And before you know it, the poor kid's getting his leg chopped off or getting a new hip because you didn't leave a bone island alone. It's good to remember that there are, in the literature, leave me alone lesions, stuff that you just let it go. And it's easy to let it go, I think, if it doesn't hurt at all in the right hip. It's harder to let this go if the patient's got a little labral tear, or they've got a little impingement syndrome, or they've got a little bursitis or hip pain for whatever reason, subluxation, and now you got a bone island. You think that somehow that makes it not a bone island. That's when it gets in trouble. So I want to remind you to leave these solitary brush borders, bone islands alone. Okay? Questions on this case? Good job. You guys nailed it. You're 1 for 1. Here we go. Now another finding case. Okay, a lot harder. So don't worry. Here's the right. Take some time. Technical, alignment, bone, cartilage, soft tissues. Make sure you look at all 4 corners of the films. Don't cheat and just centralize. Look at all 4 and clear the whole film. Okay. If you see anything, let me know. And this was harder. You may not see it. I didn't see it till the very end of my report. I did a little, not mentioned above, but also present line and impression.
Well, the top left, something going on? Top left?
Top left of the film right up in here. Whoa.
Yeah.
Oh, let's go back here. All right. Are you guys seeing that icon?
No.
No.
Okay. For whatever reason, I'm seeing the icon up there. I'm not sure how to get rid of that. Okay. Yeah. Well, there's an earlobe here going on. I chased an ear, guys. It was pretty embarrassing. My first year as a radiologist, I saw an ear on a digital film and I chased it and got a whole workup on it. That was a little rough. I'm not sure if that's what you're seeing, but I have chased that before. I've got an actual MR to follow up on the guy's normal earlobe. But everything else, I don't see anything else up on the upper.
Right first rib. Is that normal? Looks a little bigger than the other one. And maybe
okay. Yeah,
right in the middle.
Okay, I agree that I'm glad you're starting to look at the ribs. There is some costal cartilage calcification right here that's normal. It does look a little bit thicker in here in this first rib, and sometimes you can have the first ribs can get stress fractures in them, and I don't see callus formation around the rib and anything that would be more specific for a stress fracture but it is a little thick, and so you could get some, it could be some stress reaction of bone in that first rib. But everyone look at the ribs now based on that finding. What else do you see in the ribs?
How about the fourth left rib?
Okay, good. So here's the left. So 1, 2, 3, 4. Good. The fourth left rib, there's a rib fracture there. And it does have a little callus formation around it. It doesn't look like it just happened, but it doesn't look like it's been there forever. It looks real, and it could be, I don't know, that could be related to that, or they could be independent findings. This looks more of a stress reaction. Maybe the kid was carrying a backpack. Guys, look for those big, thick ribs like that. Some people carry bags on one shoulder. You do that at college for too long, and you'll thicken out that first rib like that, and it could develop a stress fracture. But there is a definite fracture in that rib. So not a huge finding to worry about fractures, but I can tell you that it's just fun for our importance of detection. And the key is you're going to only see that if you do technical alignment, bone, cartilage, and the soft tissues on your flow, and you look at all 4 corners. And when you look at the soft tissues there, that's when you're going to see it. You're going to say, okay, I'm going to kind of look at the upper lobes of the lung and make sure that I'm not seeing anything there. And boy, when you start looking up there, you'll catch that rib fracture. So yeah, I think it's a subacute rib fracture. Good pickup. Let's go on to the next case. 43-year-old male with severe lumbar pain. All right. We're going to go pretty quick on this one. If this is, let's see, 5, or if this is L2, what level are you most concerned about, docs?
L4-5.
Right. So we're all concerned about L4-5. What's obviously our finding is disc space narrowing, but what else do you see other than just disc space narrowing?
Is there a Schmorl's node at the superior end plate of L5?
Yeah, a question of a Schmorl's node. Okay, what else?
Seems like the end plate is irregular, just kind of not real defined.
Okay, good. So good differential and good forensics. This is why I want people to detect my students. Instead of trying to slam dunk it, I like it. The end plates, I mean, if you look at that end plate and that end plate, I mean, those are beautiful. Real nice here. Boy, they're just not as clear. And there is some narrowing. And it's not like there's big osteophytes popping out there either. So you don't have a lot of other signs of degeneration, but you've got pretty focal narrowing, quite a bit of it with indistinct end plates. Could there be a Schmorl's node here and that's secondary degeneration, and maybe it's moving a little too much there from old trauma in adolescence? Yes, I think that's a legitimate differential here. But you can't blow off the irregular end plates on both sides of the disc. So what is probably the most scary diagnosis when you get focal narrowing, not a lot of osteophytes, not a lot of sclerosis, but you get some indistinct disc? What's probably the most common or the most infection? Right.
Discitis, infection.
Right. So infection, and sure enough, we got an MR. We pulled an MR on this guy, and it was a disc space infection. Guess what? With a Schmorl's node at the superior end plate of L5. So good job. You guys are on it, but I think that's, if you're aware of that and just be reminded of that information, that's huge. Okay, 59-year-old male with stiffness and neck pain with bilateral foot numbness. Okay, I've got the last case I don't have a quiz question on. This case I do. The first case I did as well, just knowing about a bone island. This one, There's your picture. I'm just going to at first just make it a little bigger so you can see, and then we'll go back and draw on it a little bit. Okay, detection. What's the big finding here? Don't give me a diagnosis. Let's start with the forensics and describing stuff.
Calcification of the ALL.
Good. So we got ALL calcification here, and notice that there's bone being thrown on right in front of the vertebral body. That's important. And what do you notice about the disc spaces?
Pretty well maintained.
Yeah, they're all maintained. So what's the best diagnosis?
Would be dish, would think.
Right. And does it matter if is it important to distinguish dish from just, hey guys, just call this degenerative disc disease? There's really no difference here. Does it really matter to make a distinction between dish and degenerative disc disease?
Yeah.
Yes.
It really does. And again, it's the associations and complications. Don't forget the history here. Look at this. Bilateral foot numbness. All right. So what could be two causes of bilateral foot numbness in a patient with dish that could be super important, a complication of dish that could create that bilateral tingling in the feet?
Stenosis or diabetes?
Right. So good. So you can have not only ossification of the anterior longitudinal ligament, but you could have ossification like that of the posterior longitudinal ligament. And of course, that makes the canal about that big, which is no good. Now, in this case, I don't see any. So stenosis from OPLL is kind of ruled out here. But guess what? It was undiagnosed. The patient had diabetes, and it wasn't being treated very well, and they were getting peripheral neuropathy, which was creating the leg symptoms. So diabetes is a very important complication, and in this case, it was super helpful to distinguish dish versus degenerative disc disease. It's important. This stuff is important.
What are the other complications besides those two?
Those are the big ones. Other complications would be the fact that while it looks like there are nice little spaces there, sometimes there's cartilaginous fusion. And some of these patients, you got to be careful of trying to force movement in there. You get a lot of, it could alter your adjustment because of the bridging hyperostosis. Also, you can cause dysphagia and difficulty swallowing because of that as well. Some people are starting to talk about hyperlipidemia in association with dish, as well as diabetes. But you know, when you come to a little quiz you might have to take, make sure you're looking more for this, but for diabetes. But still, hyperlipidemia is starting to get some press with diabetes, or with dish. Good. 55-year-old male. I got to get through a few more cases here so you have everything for your quiz. 55-year-old male with thumb and wrist pain. Okay, test question here. All right, thumb and wrist pain. Tougher case. Let's first detect. And I'll be real nice, and we'll see if I can make this bigger for you. All right, couple of findings here. Two kind of important findings here.
Got sclerosis at that scaphoid. What is it? Capitulum or caput? What is trapezium?
Trapezium.
Right. Or yeah, or trapezoid. It's hard to because you've got you got two of them in here that are superimposed. But excellent pickup right here. There's probably moderate joint space narrowing, subchondral sclerosis, osteophyte formation. Diagnosis for that is?
Well, you'd say DJD of the joint.
And I'll tell you what, DJD, you guys know this one. It loves the thumb, right? The base of the thumb. But it also really likes that articulation as well. And that can mimic a scaphoid fracture because you get a little trauma in there, and now you got scaphoid pain. And boy, you guys know good and well you don't mess with scaphoid pain. You want to mess a professional hockey player or a hockey player's career up, go ahead and miss a scaphoid fracture. And so these can mimic fractures of the scaphoid because of the degeneration hurts right there. Okay, second finding. I agree with the degeneration. Now look at the joint spaces now. What do you think about the joint spaces?
Well, that one's decreased. Are you?
Yes.
The scapholunate.
Are you thinking that's increased?
Yeah.
Scapholunate?
The scaphoid, exactly. Good pickup. The scapholunate a little wide compared to the others. Now look at the appearance of the lunate. How might you describe that?
Looks like it is. It would probably end up being a dislocated or a perilunate dislocation, but it looks like it's either volar or dorsally displaced and rotated.
Okay, so I'm going to just outline this lunate, and you see that the lunate kind of overlaps. It doesn't just stay in this row, and then you got another row of these carpal bones. It kind of overlaps. In fact, we used to learn this in class back years ago, called the pi sign. The pi sign. When the lunate is not in normal alignment. So we kind of need a lateral view here, and so here you go. Let's get this maybe a little bit bigger for you. There it is. Now, what do you think about the alignment of the lunate on the lateral view?
Yeah, it's palmar.
Well, okay, so here dorsal is by the L back there. So let me go back. Let me draw it out for you. So the lunate ought to be sitting right here, like this. You know, think of it as a boat. There's the water and the nice little boat. Fishing's coming up. I'm going to do some walleye fishing at Lake of the Woods here in 2 weeks. That's about all I think about. So there's a boat. That's a normal lunate, and the capitate is supposed to go right in there. And of course, the distal radius right there. There's a normal alignment of the lateral wrist. But here we see look at the lunate on this thing. Which way is it tilted?
Dorsal.
Yeah, it's dorsal tilting of the lunate. And you know that when you get that wide scapholunate joint, the whole wrist destabilizes. There is not a finding in the wrist other than a scaphoid fracture that's more important to see than a wide scapholunate joint and a dorsal tilting. It does very rarely tilt ventrally, but most of these are dorsal tilting. They actually have a name for this. A dorsal intercalated segmental instability pattern. DISI. A DISI. A dorsal intercalated segmental instability pattern. It's simply widening of the scapholunate joint space, which is very clinically significant because the scaphoid tends to rotate this way and the lunate tends to rotate backwards and the whole wrist destabilizes. So I think that's what's going on here. There's a number of findings, right? Now capture this. Technically, it's a great film. Alignment, okay, TABCS. Technical, it's okay. Alignment, bad. Bone, we got degeneration and sclerosis. Cartilage, we got narrowing on the one hand, but we got widening on the other hand. So we've got findings here, and a lot of times when we make an alignment finding and we get, we're real happy with ourselves, so we stop our search and we don't look all the way through the soft tissues. And just to remind you, I mean, there's a lot going on here, degeneration and alignment problems and widening of this and all the pi signs. So pretty nice case of scapholunate joint widening, scapholunate dissociation with a DISI instability pattern with nasty degeneration of the trapezium scaphoid articulation. And you know what the ironic part is? And maybe it's not ironic to you. You guys are in practice. You know what hurts here? The degeneration. The other stuff is chronic and it wasn't causing a lot of clinical symptoms. Anyways, let's go on. All right, 58-year-old female with thumb pain not responding to care. Okay, it's another fun case. Again, 58, a little older, not much. You know, I'm 47 now, so that's really young now. Thumb pain. You know, guys, if you send me an x-ray and you say, hey, Dr. Rich, can you take a look at this x-ray for me? And I write a report up for you. You say, hey, there's a history of trauma. I get a little nervous. You say, there's a family history of cancer. Maybe. Well, you know, that's pretty common. You say all these things trying to get me worked up on, you know, the transmittal form that you send in. Doesn't really work me up much. Here's what works me up. When a good doctor, good DC like you guys and gals say, hey, Dr. Rich, take a look at this. They're not responding to my care. You've diagnosed them with a strain, and they're not responding to your care. I mean, there's really only two possibilities. Number one, you've lost it. You're not any good anymore because you can't get a sprain strain. I mean, if we can't get sprain strains better, I mean, what are we doing, right? Or number two, it's not that. There's something else. So you send me a case that's not getting better and you called it a sprain strain, I look really hard. Let's just say that. And so here we go. I'm looking really hard on this case. Here it is, and so should you. This is a major important detection issue. So take a look at it and see if you can make a finding here. It's not easy. Hurts in the, and it'll be nice, it hurts, they said thumb pain. All right, so let's see if we can, I know you're still looking, but let me be nice and kind of do this and just, there you go. All right.
Thumb pain.
The radial loosened in the thumb.
Okay, what bone of the thumb?
Was that proximal flange a little?
Okay, good, very good. All right,
Right.
now I'll take the red away, and let's see if I can make this bigger here.
There you go.
Now, of course, it's nice to have two views at 90 degrees. You see that? Now look at something. Has the cortex broken here?
No, but there's definitely some invagination on that palmar side of it, it looks like.
Nice. It hasn't broken, but you can see what's called endosteal scalloping. It's like it's thinning the cortex a little bit. It just looks like it hurts a little bit. And here's another view, and I think the other view is a little bit even easier to see. There we go. Let me make this. There. See what I'm seeing now?
Yeah.
So, okay, good. So what is the most common, okay, this is a quiz question. So What is the most common non-aggressive tumor in the hands and feet? Anybody remember? And of course, I'll review it with you, but what is the most common non-aggressive tumor in the hands and feet? Anybody remember?
Osteochondroma.
Yeah, right, inchondroma. Okay, write it down for your quiz question. What is the most common non-aggressive tumor of the hands and feet? Inchondroma. Now, the problem is this, guys. Here's the problem with this. Inchondromas, they don't hurt. And the history on this person was thumb pain. Now, you could have thumb pain from degeneration in these articulations, or maybe they jammed their thumb or whatever. I understand that. But if you poke in that bone and it's deep, achy kind of pain that's kind of consistent, not constant, but kind of, you know, always bugging them, then that means that lesion's probably hurting. And if that lesion, and you thought it was an inchondroma, but that inchondroma is hurting, what's a better diagnosis than inchondroma?
A hairline fracture or stress fracture of it.
Well, that's a good point. If they jammed their thumb and you have a benign inchondroma and they jam their thumb, they could get a fracture through there. But I don't see a fracture. I don't see cortical offset. What I actually see is thinning, thinning of that cortex right in here.
So like a giant cell tumor?
Well, giant cell tumors can occur in the hands. They're not as very common, but I think here's the lesson for you, since this is most common, just for by way of review. If you think somebody's got an inchondroma in the hands, but it hurts, it's probably not an inchondroma. It's probably
A Mets?
It could be, but it's probably a low-grade chondrosarcoma. So most of inchondromas which hurt have turned into or are turning into low-grade chondrosarcoma. Yes, Mets would be on the DDX here because it hurts. But it's acral Mets, you know, it's distal. So we're dealing with lung type of, mostly lung cancer and kidney that goes distal. But in this case, if you think it's an inchondroma and it hurts, you gotta go ahead and get the MR. If this hurts, you got to get the MR. You got to see if they may have to buy, this could be a low-grade chondrosarcoma. Okay? So the most common non-aggressive tumor in the hands and feet is an inchondroma, but if an inchondroma hurts, you got to think of a low-grade chondrosarcoma. All right, here's an 85-year-old female with no pain in the hip. No pain. Now, kind of older, but no pain in the hip. So there you go. There's a finding that pops when you hang it up on the view box or put it up on your digital screen. All right, so it's kind of like in Tommy Boy, right? You know, where does it hurt? My face hurts. Where does it hurt? Well, not so much here, not so much here, more in here. Again, the finding is not so much, there's nothing going on in here. Wow, there's the finding. But here's the important piece of information. Now, of course, you're poking it and you're prodding it and you're asking for questions and you're really thinking about it, but there isn't any pain there. So with kind of central calcifications, here I don't see cortical breakthrough. I don't see cortical breakthrough. In fact, I'm looking for endosteal scalloping like I saw in that thumb, you know, thinning and digging into that cortex. It doesn't really look like much of that. So with what would be your differential on a case like this?
Could it be a medullary bone infarct? Don't they look like that a little bit?
Yeah, good. That's one. I like it. Bone infarct. Could look like that. And of course, it's got calcification in it, and it's not painful. Doesn't have to be in the hands and feet. This could also be what? In chondroma. Right. So here's, but, and then you're always having to worry about this. Low-grade chondro. Especially because of the age, right? But it does not hurt. There's no pain. So no self-respecting chondrosarcoma is going to be painless. No, it's just so let's ask some questions. Like, I want to see what you guys would do with this. How do you manage this? What are you going to do next from an imaging standpoint, if anything? What are some follow-up options here?
Well, to get a good look at it, you'd maybe do an MRI if you wanted to look at it.
Okay, you could get an MRI, and of course, this is extending off the edge. We're not sure how far down it goes.
Right.
So we might, right. So good, an MRI that would show probably if there was any cortical break, and it would see if there's a soft tissue mass with it. And that would be somewhat helpful to figure out. But before you maybe spend the money on that, before think about what you might do with just plain films or digital imaging.
So you could
hit me on that.
Comparison of the other hip and a long bone of the femur as well.
Okay, a long bone. A comparison. And then what if you wanted to know if this has been there a long time? So they're 58. Chances aren't completely out of, it's not out of the question that they might have some old film. So before I start pulling MRIs and having some dumb, I shouldn't say that, it's mean, having some radiologist who's not good at bone and joint. Call this a chondrosarcoma or a MET or an osteosarcoma, and get everybody chasing it and chopping stuff off and cutting stuff open. I might say, hey, I'm a chiro. I'm conservative. I'm going to start with plain film. Let's see how big this is. There's no pain there. That's really helpful. Okay. It shouldn't be aggressive. There's no pain. And let's get old films. If we've got old films and we see that there from 5 years ago, is it anything bad? No, it can't be. So I think checking to see if there's old films. Yeah, getting a long bone study, making sure we see the whole thing. Is there any areas, a spot view right there in the hip, right over it to make sure we're not seeing anything. Really careful clinical correlation. Check for old films. If there's no pain, you might still leave it alone, even if there aren't old films, and say, hey, it's going to be one of these. Problem, you could get a bone scan. You could get a bone scan. A bone infarct is going to be really, really, won't have any uptake. The problem is sometimes big enchondromas will show a little bit of uptake on the bone scan, and then everybody's got their undies in a bunch. And they're starting to, biopsy, and they're getting out of control. Drives me up the wall, you guys. Sometimes overcalling stuff. That's the theme today. Overcalling stuff can be just as painful for everybody as can undercalling stuff. So I would definitely get a long bone study comparison. Good idea. Old films, clinically correlate. But then you're right. Next one would be an MRI. Get a good read on it, and if you get a good read, they'll probably be able to stop right there before biopsy and leave it alone. Any questions or comments with this? Anybody disagree? It's okay. Debate, argue, talk about fishing. We're going to be done after I got to do one quick other case, and then we'll be done. Any questions on this one?
Nope.
We're good?
Good.
Okay, 23-year-old, so now younger. Now they're younger, just dull, but dull hip pain. Not much, but a little pain. All right, another case. So again, we're seeing something in the left hip. Now, do you think that this looks aggressive or non-aggressive?
It's sclerotic, but it still looks a little concerning.
Okay, Wayne, is that you talking?
Yeah.
Wayne, why do you think it looks concerning?
Well, the border's not real smooth.
Okay,
It's a large border on it. It looks cystic, but with a large border.
that's a good description. Let me write that down, large border. Okay. All right. Do you guys see any definitive periosteal reaction or soft tissue mass or that cortical breakthrough that would cause those kinds of things on this case? Anybody see that? Okay, yeah, I agree that there's no ACE for definitive cortical breakthrough here. And I'm going to kind of maybe expand that a little bit. And if you expand it, the rim around the lesion in the neck of the femur is really thick. It's really thick. It's a kind of, and that's what was, I think, the large border. I think Wayne said that. Someone said that. I think it was Wayne. And I think what he's describing is, look at that thick border like that. Now, let me be real. Let me show you how important a description is. Just seeing that. I mean, just tell me your heart on this, guy. Share your heart with me. If something's got a thick border like surrounding it like that, does it feel like it's been there a long time or a short period of time?
Long.
Right.
Long time.
Right. Your gut says long time, and you're right, because of the thick. Now, of course, if I say to you, there's a thick rind of sclerosis and a little bit of a ground glass appearance in the central aspect of this lucency with no cortical breakthrough, no periosteal reaction, and no soft tissue mass, then now what's the diagnosis?
Is it Paget's maybe? Does Paget's do that?
Well, it's a good point that Paget's does cause cortical, but Paget's typically causes cortical thickening.
Okay.
And this is something inside the bone that looks like cortical thickening. It's almost like there's bone inside there.
Would it be a bone, just a large bone cyst then? Annual bone cyst?
Well, no, those are typically more painful and more expansile. But when you get a thick rind of sclerosis with a ground glass, that's pretty classic for fibrous dysplasia.
Okay.
But here's my point. I don't really care if you can slam dunk the diagnosis. We just keep working on it. Is more just to remind you, okay, this radiographically with a thick rind of sclerosis, it's a sign of a non-aggressive process. It's virtually definitive for a non-aggressive process. And in this case, it's going to be fibrous dysplasia. So the problem is we've got dull pain. And so we get confused, like, well, maybe this hurts. And, but you know, you can have dull hip pain for a million different reasons. I would definitely call this fibrous dysplasia, and it's a leave me alone lesion. And guys, if you can't leave this lesion alone, then send it off to a radiologist, transfer the legal guilt, the legal burden to someone else's report, or at least share the burden. And don't let these pathologists get their hands on this person. I don't want them to mess it up. The fibrous dysplasia has so many different cell types that they biopsy sometimes fibrous dysplasia, and they call it something that I don't like, and it really ticks me off. You can tell. I'm not happy about it. It's not good for the patients. You know, radiology is important, and it's a lost art. We are the last that are really doing this kind of thing. Even the bone and joint MD radiologists, you know, you think they're playing around with plain films and digital X-rays very much? Not as much as they should. They're going right to the CT, right to the MR. They're going right after it, and we have this, and we need to continue to be good at it. So here's the lesson: you could get an MR here, but if you have old films and if you got a thick rind, I would leave it alone and treat them, and they're going to get better. And if they don't get better, fine. Get an MRI in that case. Go ahead. But I bet you're going to find a labral tear. I bet you're going to find a little impingement, femoral acetabular impingement, a little bit of other things going on. I doubt that that's going to be the cause of the patient's pain. Okay, good. Any questions, guys, as
Nope.
we wrap up?
Very good stuff.
Good stuff.
Good, helpful. Okay, here for your quiz. Okay, remember solitary with brush borders is a?
Enchondroma.
Solitary with brush borders, though. That's a bone island. Okay, bone island. Complications of dish that causes tingling in the hands and feet. Diabetes. Dish is important. Don't blow dish off. The scapulae joint space. Everyone, please look at that joint. That's significant. The most common non-aggressive tumor in the hands and feet is?
Enchondroma.
And a thick rind of sclerosis, is that a sign of aggressive or non-aggressive?
Non-aggressive.
Non-aggressive.
Okay, go take your quiz. I hope I see you guys soon.
Yep. Thanks, Jeff. Take care.
You bet. You bet. Have a good one.
All right, thanks, thanks, Jeff, and thanks everybody. And I'll be emailing out the link to the quiz as soon as we hang up. So have a good day.
Okay, good. Okay, Jeff, have a good one. Anything we need to talk about? We can talk on the phone about other stuff, but everything good with this class here? Are we done?
Yes. Yep, we are done. Very good.
Okay. Okay, thanks, man. Talk to you soon.
See ya.
Okay, bye-bye.